Welcome to the deep dive. Today we're getting into something really critical in the IVF journey, deciding when to do the embryo transfer. It's where all the science and strategy come together, right? And pretty much every patient is wondering, day 3 or day 5, which one gives that embryo the very best shot?
It really is about timing, about synchronization, and honestly, there's no single right answer for everyone. But let's start with what we actually mean by day 3 and day 5. So day 3, that's when the embryo is at the cleavage stage, usually about 6 to 8 cells.
Still pretty early days then, dividing fast.
Exactly. But if we let it keep growing in the lab, hopefully it reaches day 5, maybe day 6. That's the blastocyst stage. And by then, things look quite different. The cells have started to differentiate. They've organized themselves.
Into what, specifically?
Well, you get the inner cell mass. That's what becomes the fetus. And then the trifectoderm, which that forms the placenta later on.
Wow, okay. That sounds like a huge developmental step. So our goal here in this deep dive isn't just about, if an embryo can survive in the lab until day 5. It's really about hitting that sweet spot, matching the embryo's stage with the uterus's window of implantation, which is super narrow. We want to break down what makes one day potentially the right day for you. Okay, let's get into it. A lot of clinics seem to lean towards day 5, towards blastocyst transfers. Why is that? What's the big advantage of waiting?
Well, think of it as a kind of natural selection process happening right there in the lab, extending that culture time to day 5.
Yeah.
It's tough for the embryos. It acts like a quality control checkpoint. Not every embryo actually has what it takes genetically or cellularly to make that leap from day 3 to day 5.
Ah, okay. So only the really robust ones make it through those extra couple of days in the dish.
Precisely. The ones that do reach the blastocyst stage, they're generally more viable. They have a significantly higher chance of implanting successfully. That's why, statistically speaking, you often see higher success rates reported for day 5 transfers. We're essentially picking the strongest contenders early on.
That selection makes a lot of sense.
Yeah.
But is there more to it? Does that extra time give the medical team other advantages beyond just seeing which ones survive?
Oh, definitely. It opens the door for more advanced testing. This is really key. Things like pre-implantation genetic testing, PGTA, which screens for chromosomal issues. That's almost always done on blastocysts, on day 5 embryos.
And why day 5 specifically for the genetic test? Why not earlier?
Good question. It's because the test itself needs a few cells, and we take them from the trifectoderm, the part that becomes the placenta, remember. We want to leave the inner cell mass completely untouched. Doing this biopsy on day 5 is structurally the best time. And crucially, it gives the lab enough time to actually run the tests and get the results back before a transfer needs to happen. So we only transfer embryos we know are chromosomally normal. It boosts the odds.
Right. And I imagine the labs aren't just, leaving these embryos sitting there. They're watching them closely with tech, aren't they? How do they pick the absolute best one on day 5?
Yeah, we use time-lapse imaging. You might hear names like Embryoscope. These are basically very smart incubators with cameras built right in. So instead of the old way taking the embryo out maybe a couple of times a day to look under a microscope, which can be a bit disruptive, time-lapse watches it constantly, nonstop.
Like making a little movie of its first few days.
Exactly like that. And it lets the embryologist see things you might otherwise miss. Subtle things, like maybe the timing of cell divisions wasn't quite right or certain visual patterns. Things that tell us about its health and potential. We can choose the best candidate based on its whole journey, not just a snapshot on day 5. But this brings up a really important point. If day 5 seems, better because of selection, why would anyone choose day 3? When is transferring earlier the right call?
Yeah, I guess I see day 3 as maybe a more protective move sometimes, like acknowledging that the lab isn't perfect and maybe the uterus is still the best place for the embryo to be. Patients worry, right? They know some embryos just won't make it to day 5 in the lab.
That drop-off can definitely happen. It's a real factor.
It is. So say a patient doesn't get many eggs, or only a few fertilized, maybe just 3, or even fewer. The team might think, okay, let's get this cleavage-stage embryo back into the natural environment now. Why risk that one potentially good embryo not making it those extra 2 days in the culture?
That's exactly the thinking behind a day 3 transfer strategy. It's often the choice when, the embryo numbers are low to begin with, or maybe the embryos didn't look fantastic between day 1 and day 3, maybe some fragmentation or signs of stress. Or perhaps past cycles showed that the embryos didn't do well after day 3 in the lab. The idea is that maybe, just maybe, the uterus can provide something the lab can't to help it along. It's always a very personalized decision, looking at the embryo quality and the patient's whole history.
Okay, so we've talked about the age of the embryo, day 3 or day 5, but then there's the type of transfer, fresh, right after retrieval, or frozen later on. This seems just as important because it's about the environment the embryo enters. Hormones must play a big role here.
A massive role, yes. This difference gets right back to that synchronization challenge we mentioned earlier. The hormonal picture in the body right after egg retrieval is totally different from a carefully prepared cycle later on. It changes the whole uterine environment.
Let's talk about the fresh transfer first. Doing it right away in the same cycle as the retrieval, what are the potential downsides there?
Okay, so with a fresh transfer, your body is still flooded with those high levels of hormones used for the ovarian stimulation, lots of estrogen usually. Now, while it's quick and convenient, that intense hormonal state isn't always ideal for the uterine lining, the endometrium. It might actually make it less receptive. So the timing between the embryo and the lining might be slightly off, a synchronization issue.
Ah, so even with a perfect day 5 blastocyst, the landing pad in the uterus might not be quite ready because of those high hormones from the stimulation meds.
That's a great way to think about it, yes. Now compare that to the frozen embryo transfer, or a ET. This approach basically lets us aim for a perfectly controlled hormonal environment. The embryo is frozen, vitrified usually, and the transfer happens in a completely separate cycle later on. This gives your body, your ovaries, time to fully recover from the stimulation.
And in that later HT cycle, how do they prepare the lining to make sure it is perfectly synchronized?
Right, so the specialist takes over completely. They use specific doses of hormones, usually estrogen first, then adding progesterone at just the right time to build up the endometrium perfectly. They can time the progesterone start to match the exact developmental stage of the thawed embryo. It's all about creating that optimal receptivity, hitting that window of implantation precisely.
It sounds like they're meticulously setting the stage for the embryo's big entrance. Does this extra control actually translate into better success rates?
In many cases, yes. There's growing evidence suggesting FET cycles might have slightly higher success rates than fresh cycles for certain groups of patients, largely because of that better uterine environment, that optimized lining. And beyond just success rates, there are significant safety and health advantages too. FET totally eliminates the risk of making ovarian hyperstimulation syndrome, OHSS, worse. That makes it much safer for patients who are at higher risk, like women with PCOS.
And the delay, that flexibility, is what makes things like PGT possible too, right? Because
Yeah.
getting those genetic results takes time. It links back.
Absolutely. FET gives you that crucial time window needed for the genetic screening results to come back. And something else that's really interesting, some research suggests potential benefits for babies born from FET cycles. Things like slightly healthier birth weights, maybe a lower risk of being born preterm compared to fresh transfers. It seems like letting the mother's body recover first might be beneficial for the pregnancy itself.
This whole process is just
Oh.
incredibly precise.
Huh.
Synchronization seems key at every single stage. So, okay, the team has decided on the right day for the embryo, the right type of cycle, fresh or frozen. What happens during the actual transfer procedure? Are there specific techniques clinics use to give that embryo the best possible chance right at that moment of implantation?
Yeah, once you have the best embryo selected and the lining is perfectly prepared, the focus shifts entirely to precision during the transfer itself and helping the embryo stick. First off, ultrasound guidance is standard practice, absolutely essential. The doctor uses ultrasound in real time to see exactly where the catheter tip is going. They aim to place the embryo in that perfect sweet spot inside the uterus, usually about 1 or 2 centimeters from the very top, the fundus.
And why is being that specific about the location so important?
Well, you don't want to place it too close to the uterine walls or too high up near the tubes. That can actually lower the chances of implantation. Plus, gentle placement guided by ultrasound helps avoid irritating the uterus, which could cause contractions that might push the embryo out.
Okay, precision placement makes sense. What about actually helping the embryo, adhere to the lining? Is there anything for that?
Yes, there is. It's often called embryo glue. Now, it's not actual glue, of course. It's a special culture medium that the embryo is placed in just before transfer. It has high concentrations of a substance called hyaluronin. Hyaluronin is naturally found in the uterus and helps with stickiness, basically. So using this medium might improve the connection between the embryo and the endometrium, enhancing adhesion.
Embryo glue, interesting name.
Mm-hmm.
Okay, what else is in the toolkit, maybe for specific situations?
Another common technique is assisted hatching, or AH. For an embryo, especially a blastocyst, to implant, it needs to break out of its outer shell that's called zona pellucida. Sometimes, especially with frozen thawed embryos, or maybe in older patients, say over 38, that shell can be a bit tough or thick. So using a very precise laser or sometimes a chemical solution, we can create a tiny opening in that shell beforehand. It sort of gives the embryo a little help to hatch out and implant more easily. And one last detail, maybe seems small, but it's important. Clinics usually warm the transfer catheter itself. They warm it to body temperature, 37 degrees Celsius. This just helps keep the embryo stable during that brief journey into the uterus and might also help reduce any potential uterine contractions caused by a cold catheter. Every little bit helps. So wrapping this all up, what's the big takeaway for you, the listener? I think it's that there really isn't one single winner here. Not day 3 versus day 5 or fresh versus frozen as a blanket rule. Day 5 transfers, sure, they offer more certainty about embryo viability because of that intense selection process in the lab. But day 3, that remains a really important protective strategy, especially when you don't have many embryos to start with.
Right. And the whole fresh versus frozen debate really highlights that timing isn't just about the embryo's age. It's about getting the uterine environment perfectly ready too. Success really comes down to that personalized plan, doesn't it? Finding the best way to synchronize the highest quality embryo you have with the most receptive uterine lining possible. And the encouraging part is, you have whole team embryologists, doctors, focusing on all these intricate timing details for you. So my advice, focus on working closely with your clinic, asking these kinds of questions we've talked about, and really trying to focus on taking care of yourself during this process, trusting that your team is using all the tools they have to give you the best chance. Now, we absolutely have to say this. Crucial disclaimer. Please remember, everything we've discussed here is purely for educational and informational purposes. It is definitely not a substitute for professional medical advice. You must always, always consult with your fertility specialist for advice tailored to your specific health situation. And if you do want to explore more about the entire IVF process, learn about these techniques in more detail, a great resource is the online portal, ivfforme.com. That's ivfforme.com.